This is our robotic partial nephrectomy model. This was designed from an actual patient CT scan. If you look in particular, it's actually from several CT scans because we have 3 tumors. We have an upper, a middle, and a lower pole tumor, each with distinct levels of penetration into the parenchyma, giving the surgeon that's performing a simulation not 1 but 3 experiences. Other than this model having undergone a significant amount of mechanical testing to make sure that the texture of the tumor, the kidney parenchyma, the pelvic calcaneal system, and the vessels actually replicate true live human tissue, we were also able to perfuse this model. And this is through these vessels that we fabricated hollow so that you can flow fake blood through all the way up to the base of these tumors so that the person performing the simulation has a true realistic experience of bleeding that happens during partial nephrectomy. But also, when they actually suture the base, they're able to control that bleeding. So truly an immersive experience. But what's more important than this is we're able to use other patients' CT scan to develop patient-specific models. And these are models like this one that we're able to have very complex tumors being recreated in the hydrogel form, where the surgeon is able to actually practice the surgery, what we call a surgical rehearsal, prior to the live procedure itself. And this we have found to thoroughly reduce complications related to these complex partial nephrectomies. But if we give a surgeon just the kidney itself to cut through, that's really not a true immersive realistic experience. What we needed to is to place the kidney within the context of the abdominal cavity. And so we created an abdominal cavity. We took patient CT scans and developed this, which is almost half the patient's abdominal cavity, with the 11th and 12th rib all the way down to the iliac crest, with all the bony and muscular landmarks, and the inferior vena cava, the kidney, the surrounding fat, and the muscle, all in hydrogel format. We surround this with small and large bowel and even cover it with a layer of hydrogel non-biohazardous abdominal wall, so that the surgeon can even practice port placement. And here you can see the tubes through which we infuse the kidney and the surrounding organs. So this is the true way to do a realistic simulation for a robotic partial nephrectomy. Showing you the actual simulation itself, here this is a surgeon performing a transperitoneal partial nephrectomy on the left side. You can see they use cautery because this is a hydrogel. All you need to do is really attach a cautery pad to the model itself, and they're medializing the colon. You can see this is the left side because there's a spleen there towards the upper pole. So again, we're keen to replicate all the steps of the procedure. Once they're done with medializing the colon, the surgeon then identifies the psoas muscle and is able to find the ureter, retract it upwards to find the renal hilum. They then start dissecting out the renal hilum. Now, the renal hilum, the artery, and the vein are both perfused. So if any injury happens to the vasculature here, there's going to be a significant amount of bleeding, which might really be a good way to teach trainees how to deal with injuries of the renal hilum during a partial nephrectomy. They're able to plan the procedure ahead of time because they have the actual patient's CT scan to guide them through that. They then open the gyrotous fascia, and you can see there's a distinct texture of fat, which is very similar to the gyrotous fascia in a patient. They undergo clamping of the renal artery, and then they start resection. In the first few cuts, there's not a lot of bleeding as usual, but then the deeper you get towards the tumor, there's a significant amount of what we like to call venous ooze because the vein was not clamped on this practice. The suction here, the assistant, is essential to keep a good plane of view. Again, a good way to teach the trainee or teach the surgeon how to deal with cutting out a perfused tumor. Now they start to do the first layer of the renorrhea, which is the hemostatic layer, and as they start to cinch it down, you see a drastic reduction in the amount of bleeding because the vessels that are feeding this area of the kidney have actually been squeezed or closed by suturing. We were very keen to replicate the mechanical properties of the kidney tissue. We did a special test to make sure that no excessive force would be used during this sliding clip renorrhea technique because we don't want to teach them to put excessive force on this part, so ripping out the parenchyma, but at the same time, adequate force to compress the parenchyma. So at the end of the procedure, there is good coaptation of the parenchyma, as well as you can measure positive margins, you can measure ischemia time, as well as blood loss.